Good afternoon, everyone. My name is Stephanie Gresh. I'm the Executive Director for the Scleroderma Foundation Greater Chicago Chapter, and I want to welcome you all to our webinar today. Thank you for joining us for this discussion on navigating the pandemic in 2021. I know you all have a lot of questions about the vaccines that are out there. We're also going to talk a little bit about telemedicine and how to make that work for you and some other topics. A lot of you have submitted questions in advance. But if you have a question during the webinar, feel free to enter that in the Q&A section at the bottom of your screen. And we'll try to address those towards the end if we have time. So feel free to submit questions as we go. Just a few reminders before we get started. The Scleroderma Foundation, we do have other resources. We try to keep you updated with other educational content, and we've got a lot of stuff on our YouTube channel you can check out. Which is youtube.com/GC-Scleroderma. And you can also go to our website to find out about support groups and other resources that we offer. And our website is scleroderma.org/GC-Chapter. And with that, we'll get started. I want to welcome Dr. Jane Dematte and Dr. Chase Correia from Northwestern Medicine. Thank you guys so much for joining us here today and talking about this very important topic. So I'll turn it over to you.
Great. Thank you so much, Stephanie. And thank you so much, Dr. Dematte, for helping here as well. Thank you, everyone, for joining us. And please, as Stephanie mentioned, if you have questions, especially as we've gone through a fair bit of the presentation, please feel free to to ask your questions on that Q&A, and we'll try to get to some of them towards the end. So the very first thing that we were going to talk about was just some observations and hopefully some helpful hints for how to make your e-visits, which are popular right now, as effective as possible. And on my end, I had kind of a few things just to mention. Number one is the timing. I know those of you who have had e-visits with us, sometimes it's been frustrating because it looks like we're always kind of running late. And just to explain that a little bit, what's happening is that when you come in for an in-person visit, you might have an 8 a.m. visit, but it takes 5 to 10 minutes to get your vital signs done and to get your meds sorted out with our MA. And so in reality, those visits, pretty much always start 5 to 10 minutes later. But when you have that e-visit that's scheduled for 8:30, let's say, the previous visit took the whole half an hour. And so the earliest that's, really feasibly possible to start that visit with the next person, if it's an e-visit, is at least 10 minutes later. So just keep that in mind. Every so often, your visit might be perfectly on time if someone canceled or something like that, but usually it's going to be, 5 to 10 minutes at a minimum after the visit was scheduled. Another thing that I have noticed, especially for those of you who wanted to show, new ulcers on the hands or new rashes or anything kind of physical, it's so incredibly helpful if you can find a desk or some other surface to have the e-visit on that, pretty much everyone is using their phone for their e-visit. And when you're trying to show, the ulcer with the phone, it can be challenging because your phone's moving a little bit, your hands are moving a little bit. And so just finding a spot to actually set your phone on and be hands-free as you're showing me things is super helpful. On a related note, every so often folks are, in the car or doing other things during those e-visits. And I certainly get it that life happens and you can't always control everything about your schedule. But please, please, please do not be driving. If you're driving, we'll have to stop the visit. Unfortunately, it's just not safe. And really, setting aside that time to have a dedicated space and a quiet place to have that visit is super helpful, just so we can make the visit as useful as possible. Jane, do you have other thoughts about how to make e-medicine as effective as possible?
Yeah, a few things I'll mention is video help is more helpful than just a telehealth call. While there may not be rashes or ulcers I want to see, it's very helpful to see somebody in terms of sensing dyspnea and their in general health. So I do like the videos as opposed to the telehealth when at all possible, which means it has to be a cell phone number. The other reason I think I want to point out we're sometimes late is it's a challenge for some of our patients to navigate these newer technologies. Believe it, it took us time to figure out all of these new technologies. And so sometimes we have to walk somebody through how to actually even make the connection. And our practice is not as good as some other practices where they have the MAs or some other help in the office making, getting somebody up and ready and running. So there is often a lag with appointments because it's taking 5 or up to 10 minutes to get people connected. So I'll mention that. The one thing, we do all of our e-visits, our video chats, and the telehealth through an application called Doximity. It has not yet allowed, or we have not yet figured out how to use a share screen so I can show you your CT scans or your pulmonary function test, which is the one things as anybody who's seen me in the office knows I like to do. So for that, I'm doing the best I can to sometimes just scroll the CT, using the camera to scroll the CT scan and whatnot. But that's another reason why I think the video visits are good though, so that we can actually look at some of that data. Those are the main things. If you have your questions, have them ready. You should be getting a phone call from our MAs the day before, or at least the morning of, to ask if you have any means to give them vital signs. So be prepared to do that too. If there's any new medications, be prepared to give them all of that information, because that does help make the visit go a little more smoothly.
Absolutely true. Thank you so much, Dr. Dematte. And someone did send in a helpful suggestion already on the Q&A, which is especially if you have an ulcer or something like that, and you're going to have a hard time showing it on the phone, you can take a picture ahead of time and send it. Just, let us know, remind us to take a look. It is apparently, I've heard from patients, you cannot just take a picture with your phone and submit it through the MyChart on your phone. You have to use a desktop computer or laptop computer to submit a photo through MyChart, is what I've been told. So let's go ahead on to the COVID discussion here. One question that was extraordinarily common in the submitted questions was, is the vaccine safe? Is it safe for scleroderma? Is it safe in general? And so the studies did exclude folks who were on immunosuppressive medicines, and that was, initially a concern. I've told many of you, any of you who are my patients, that I've been keeping very careful track of the numbers of patients who have scleroderma who have received the COVID vaccine, the full vaccine series. And right now I'm at 36 patients who have received the COVID vaccine. Very well tolerated overall. As many of you know, that second shot, if you receive either the Pfizer or Moderna, is the one that tends to have more side effects, but they are temporary, anywhere from 24 to 48 hours of, muscle aches, low-grade fevers, feeling fatigued. I personally got it, and I felt like I kind of had some flu-like symptoms for about 24 hours, but they go away. We have not had a single patient so far who has had any permanent side effects, and definitely no flares of their scleroderma. Dr. Dematte, do you have any other thoughts on that particular question?
No, and I certainly think it's far safer to be vaccinated than to get COVID. So
yeah,
as soon as you're eligible, get the vaccine.
Absolutely. Absolutely. Now, someone here has a question that Dr. Dematte actually has a great graphic prepared for us. Thank you so much for doing that, Dr. Dematte. Does pulmonary fibrosis qualify for phase 1B+?
Okay, so I'm going to share my screen here. Here we go. So, to address that issue, I'll tell you where we're at in Illinois. Here we go. So in Illinois, we're in the 1B eligible individuals in some parts of Illinois, we have moved on to 1B plus, which I'll talk about in a moment. But so the 1B group is still individuals greater than 65 years of age, or those with specific, other risk factors. So those in education, those in food, agriculture, manufacturing. So not only frontline healthcare workers, but frontline workers who can't protect themselves because they're working in closed settings or interacting with the public. So this right now does not include anybody with underlying illnesses that put them at higher risk, whether it's immunosuppression or lung disease. Those begin in when we hit phase 1B plus eligible individuals. Here is where the pulmonary disease, obesity, diabetes, heart conditions, and other things. Immunosuppression, I think, should be in here, but anyway, these are the 1B plus individuals. So as of February 25th, these went into effect in Illinois, but a number of counties, including Cook County, have opted out. So at this point, Chicago is not in phase 1B, but it is anticipated, and I think that's simply because they felt they weren't far enough down the 1B versus the 1B plus, but they have not yet begun the 1B plus eligible individuals. That's when you'll all come in. I do anticipate that is going to be within the next, certainly within the next week or so, that they should move on to the 1B plus eligible. And then I had this little slide here in case you're wondering, so, how do I get the vaccine? This is a question that almost everybody who comes into my office asks. So first of all, in terms of how Northwestern is handling it, Northwestern is handling it using sort of the state guidelines. Anybody who's 65 years or older, that's their first cutoff. Then they're going to look within the age of 65 at certain zip codes where they've been hardest hit with COVID infections. Those might include areas that have a lot of frontline workers, for instance. And so they're going to work those zip codes within that age group first. And then they're also going to look at comorbidities within that age group. And so sort of prioritize within age groups. And then they're going to back down on each age group as it goes. They have left physicians out of this decision and triaging policy, in part so that we weren't having to advocate for individual patients and basically fight against each other of whose patients should be vaccinated first. So they will contact you. If you have seen a specialist in Northwestern, if you've seen an internal medicine or a specialist within Northwestern in the past 2 years, you are on their list. They will then communicate with you via whatever method you said you preferred to be communicated with, whether that's a MyChart message or a phone call or whatever you indicated. They will let you know that you are eligible and you can go ahead and schedule your vaccine. That being said, the scheduling process has not been easy for many people, and the schedule is way booked up. So I would encourage you to look for other venues for being vaccinated as well. This website, it's a lot of letters, so all you have to really do is Google where to get a COVID vaccine in Illinois, NBC, is an exhaustive collection of all of the different places with links where you might get your vaccines. They have all the state-run National Guard centers up there, who's open, who's not, where they are, what their hours are, how to make an appointment for those sites, as well as, Walgreens, Walmart, all of them there with links to how to go. And then when you reach most of those sites, I haven't been to all of them, but most of them will walk you through the process. But I think diligence is the key here. If you go in one and there's no available appointments, you got to keep at it. You got to keep going back and checking again and again through the course of the day or the week to try to get appointments. I mean, I've had young folks who managed to get appointments at the end of the day because there were extra vaccines. So I think it's just all about diligence. So if we go back, oh dear me. So these are the groups, the 1B plus. So if you're on one of these 1B plus conditions. They don't specifically mention immunosuppression here, but most of the other diseases.
I know a question I've fielded quite a few times is, do you need a letter from your physician that you meet these criteria? I do have one single person who did, but most people are not. And I even saw yesterday that Governor Pritzker, for those of you who live in Illinois, he said that it is on the honor system, that they are expecting people to kind of, not have to prove it. But in some cases, I have had patients say that, yeah, they showed that they are taking a medicine for their chronic lung disease, or for their diabetes or something like that. Okay, so the next question is, many different forms of this question, but I am on such and such medicine. Should I hold it for the vaccine? And this is something that we only somewhat recently got guidelines from my professional society, the American College of Rheumatology. And we're going to cover that here next. But the bottom line is that for the vast majority of folks who have scleroderma, and I'm including those who are on methotrexate and mycophenolate mofetil or Cellcept or Myfortic, any of those forms, do not need to hold their dose prior to a vaccine. And that's what's on this slide right here. You can see over on the left side, the left column is the medication. So you have hydroxychloroquine, you have steroids for those of you who are on low doses of steroids, you have mycophenolate and methotrexate. If you, I'll do methotrexate later, but any of those other medicines, you don't have to think about it at all. Just continue your medicine and get the vaccine. With the methotrexate, if you have completely controlled disease, then you do have an allowance to hold the methotrexate for a week after your vaccine dose. However, many of you who are on methotrexate are on it because you kind of have more advanced disease. So I would only do it if you've, at least on my end, if you've heard from me that I would like you to hold the methotrexate. Otherwise, I don't know that I think the benefit is really worth it there. There are some of you who are on it for, because you mostly have rheumatoid arthritis, and that's really the dominant kind of disease that's active in your overall disease. And some of you, I might have you hold it, but most of the time I'm just continuing through with it. Then the next slide shows rituximab and cyclophosphamide. For those, it is a trickier situation, and I'm going to address the rituximab first. That's that second medicine. So if you have, if you're on rituximab, then you want to get the rituximab about 4 weeks prior to your next scheduled rituximab cycle. Some of you are on every 6 months of rituximab, and if that's the case, that's exactly what we'd like you to do. So 4 weeks before your next due. But after the vaccination, you have to delay the next rituximab by 2 to 4 weeks. Those of you who are getting the Pfizer or Moderna, that means that we're going to have to delay the rituximab by a little bit, because you're going to start getting your vaccination 4 weeks before your next dose. Then you're going to wait the 3 or 4 weeks, 3 weeks for Pfizer or 4 weeks for Moderna for your next dose of the vaccine. And then we're going to have you wait 2 or 4 weeks after that second dose. For Johnson & Johnson, these guidelines actually haven't yet addressed that question, but we imagine we're going to wait about 4 weeks after the Johnson & Johnson vaccine before you get your next dose of rituximab. So it is confusing. We'll leave this one up here for a little bit, but there's a lot of timing involved for those of you who are on rituximab. Cyclophosphamide, if you are on that medicine, then you are going to want to have the cyclophosphamide administered 1 week after each vaccine dose, because this is typically a monthly medicine. But there's not many folks who are on that medicine anymore. Dr. Dematte, other thoughts there?
No, I think that about covers it. The most difficult thing is you mentioned the timing of the Rituxan, especially since it's difficult to get a schedule for your vaccine. So this is something I hope gets a little less challenging as vaccine availability is more is more available.
And I cannot say it enough that we recognize how incredibly challenging this is. Many times it's hard enough to schedule either the vaccine or the rituximab, and now we're asking you to kind of figure out how to schedule both of them together. It's something that our infusion clinic is aware of, and it's going to definitely take a lot of logistics, but we are working on it. It's unfortunately, a very challenging thing because we were quite busy and quite full even before this guideline kind of changed the operations here. So we absolutely acknowledge how difficult that is, and we will absolutely try to work with you on making this happen. Okay. Now, another question that did come up quite a few times was, can you compare the different vaccines for us? What's the, relative efficacy, and what are our recommendations surrounding the different brands of the vaccine? Dr. Dematte, you made this great chart for us, so I'm going to let you walk us through this.
Right, and I think this is really important, especially as we talk about Johnson & Johnson. So, both Moderna and Pfizer are RNA viruses, RNA vaccines as opposed to DNA vaccines. If we have a chance and people are interested, we can talk a little bit about what exactly that means. Both of those two vaccines, the Moderna and the Pfizer, were the first two approved with very high efficacies, both well over 90%. Their primary outcome measure, you should understand, was prevention of symptomatic infection. So they did not swab anybody after, the Pfizer vaccine swabbed people between the first and second dose. So they were swabbed before the first dose and then before the second dose. And they compared swab positive in the patients who got the vaccine versus those who didn't. But they didn't swab anybody else. And so they didn't look for asymptomatic infection. After the point of the second vaccine, it was simply whether people became clinically symptomatic, and then they were swabbed for symptoms. So we don't know anything in terms of either of those vaccines and whether they are able to prevent transmission of the disease, because it's quite possible there was asymptomatic carriage in those patients. I think most of you know the Moderna, it's 1 month first vaccine, 1 month second vaccine. In the Pfizer, it's 3 weeks with the two vaccines. And vaccine, when we're looking at antibodies to assess response, tend to peak by about 1 to 2 weeks after your second vaccine. So that's when we think that immunity probably is established. How long it lasts, we don't know yet. So Johnson & Johnson, a lot of people have looked at that 66% efficacy and said, oh, well, I don't want that vaccine, or it's not as good. But actually, they had a very different outcome measure. They had a combination of positive tests and at least one symptom, beginning anywhere from 14 was one outcome, and then they have a second outcome in 28 days after the single shot. And so what that meant is they swabbed everybody, and everybody got a swab. And if their swabs were positive, then symptoms were searched for as well. So that wasn't everybody, but it was a number of patients in that vaccine. So their outcome was a little bit different. And that was one of the reasons that they had lower efficacy. It was the way they designed the study. If you look at severe disease, there was none. So there was no hospitalizations and no deaths. And then also a couple of other things to remember about the Johnson & Johnson is that if you looked at the efficacy just in the United States, it was 72%. If you looked at the South Africa population, it was 57%. And actually it was even lower, or no, it was somewhere mid between them in the 60s in those in Brazil. All of these areas showing variants now. So if you look at testing time frame, both Moderna and Pfizer were testing their patients prior to the advent of these variants, whereas the Johnson & Johnson was testing their patients during the variant spread as AstraZeneca, which is most likely going to be the next one coming up, also tested their patients during, tested their vaccine during variant spread. So there are several reasons why Johnson & Johnson may look as if it's not as efficacious as Moderna or Pfizer, but related to different outcome measures and different time frame of testing. But there were, if you look at the development of severe disease requiring hospitalization or deaths, it was just as effective as were the Moderna and the Pfizer vaccines at avoiding those types of infection. So I think those, and then I just mentioned the AstraZeneca in part because, and I think I mixed a little bit before what I was saying, the AstraZeneca was the one that, whoops, sorry, let me go back. Whoa. Was the vaccine where they did weekly swabs in all patients in one subset of that to detect asymptomatic carriage. So this is our first indication of whether or not vaccination is preventing asymptomatic carriage. It will be in that AstraZeneca data when it is published. And I'll make one other comment about the Johnson & Johnson. They used one dose and found it was 72% effective. There is some ongoing research now looking at a second dose, and early signals seem to be that it gets efficacy up into the range where Moderna and Pfizer were. So I just want to point that out. And I think that's it. If people have other questions or want to know a little bit more about the different types of vaccines, we can talk about that later.
Yeah, thank you so much. So bottom line, and I really think that we are on the same page here, is that the level of effectiveness of these vaccines and the level of risk that the COVID virus presents to everyone is that definitely just get the first vaccine you can. If you're offered a vaccine, just say yes. That's really, I think, what we both feel, because unfortunately, and Dr. Dematte, more than me, we've seen bad outcomes from COVID infections in a variety of patients, unfortunately.
Chase, this might be a good time to talk about then what happens when I do get my vaccine.
Yeah,
can I
absolutely.
stop my mask? Can I?
Yeah, so these are really tough questions because just to clarify, we're talking about the question, I have my vaccine, when can I return to normal life? And it really is an extremely, tough question. One issue is whether you can still transmit the virus. And, as Dr. Dematte kind of mentioned with some of those previous studies, unfortunately, it has been shown that even though you may be protected from a severe infection or from any infection, it's still unfortunately possible to transmit the virus. And so, that means for some of you, you might be qualifying earlier than other members of your household because of your condition. And, you still want to wear masks and be careful and be socially distanced to protect those other family members. But likewise, unfortunately, even those other people in your life who you might want to get together with again, they may be able to transmit that virus to you. And so, Dr. Dematte, you made this slide here. Would you like to go through it with folks?
Yeah, just to talk about, most vaccines offer effective immunity. Very few actually sterilize. The difference being effective immunity, it protects you from getting a virus that will make you sick. So influenza is an effective immunity. It doesn't prevent you from acquiring it, just from not having a bad case of it. Sterilization immunity is the one that is very hard to assess, and it prevents you from being able to transmit it, and really is what allows herd immunity at much lower levels. How much sterilization you get is what dictates how much herd immunity. Herd immunity being the idea that not everybody has to be vaccinated. If 60% of the population is vaccinated with the sterilizing vaccine, then it's sufficient. But if the vaccine does not cause sterilization, you need upward of 80% or higher of the community to be vaccinated before you have herd immunity. So this whole notion of whether the COVID vaccines are effective or sterilizing, we don't 100% know, but early data that they're clearly effective, but that they're not likely, at least not from what we can tell and what we know, to cause sterilization. So you can still have local, what that means is you'll get the virus and it may actually replicate within your nares, and you can still spread it from there, even if you don't get a systemic illness, even if it doesn't become, more spread throughout your body, it still can be localized enough where you can spread it. And that's what we think the asymptomatic infections are all about. This sort of, hinges a little bit on the viral load that you carry in your nares, because we do know you can find it there. If those viral loads are much, much lower in patients who are immunized, then we may actually be closer to sterilization immunity than we think. But we certainly don't have any data right now to suggest that we have sterilization immunity based on these vaccines, which means potentially you can still transmit it. And it also means you can't rely on the fact that 50% of the population or 60% has been immunized to protect yourself. So,
yeah. You may have said it, and I apologize if you did. Herd immunity is generally going to be somewhere between kind of the 60 to 70% of the population being immunized and vaccinated. I do, keep in mind that in a global world that we have now, we're not necessarily just talking about, Chicago, Illinois, the US, but the world, really, unfortunately. So do kind of keep that in mind. We're not just, or maybe I'm not just being a nervous Nelly when I'm kind of advising caution and advising to kind of be patient with going back to your regular life. But it's because of some of these facts. It's going to take a while for us to get up to 70% of the US being vaccinated, and all more longer before the world is. I do think some kind of practical suggestions, and you'll probably get healthy differing opinions from various folks, but I personally am not quite to the level of indoor gatherings outside of your family and things like that yet. I'm much more comfortable with outdoor gatherings where people are wearing their masks, and especially as the weather gets warmer, hopefully that's more and more possible because of all the folks who are getting vaccinated now.
right. And I think, you pointed out it is a global, it's a global economy, people travel quite a bit. Well, maybe not as much now, but also gets to the point that we don't know a lot about these newer emerging variants. And again, not to be an alarmist, but neither Moderna nor Pfizer really have any data or usable data at this point on the 3 variant vaccines that are circulating now. The Johnson & Johnson got some protection against the South African one, but that may also be a game changer. And another reason why I think it's too soon to really let your guard down at this point, even if you've been vaccinated. So.
Yep. Unfortunately true. This one is, I really like this question. So how do doctors avoid Zoom fatigue when their appointments are virtual? I did like that. Me personally, I just want to take care of folks. I really do. And so I don't actually feel personally a whole lot of Zoom fatigue with the virtual appointments. I do have to admit that I think that we can do a lot more than I ever thought possible with the virtual visits. But there are certain things that are really tough with virtual visits. One of those is in patients who I've had, for a while, very hard to assess if the skin is getting worse or not. And so if you kind of feel like, yeah, maybe it's getting worse, that's something that's much easier to evaluate in person. And I apologize if you're hearing my daughter there in the background. I don't know that I have specific tips or tricks for avoiding Zoom fatigue. I like connecting to people, and I find that I'm connecting to people in person and on the Zoom visits. The biggest thing that I kind of miss is smiling at folks and seeing their smiles back, and that's tough whether it's in person or Zoom. So, do you have any tips, Dr. Dematte?
No, Zoom meetings are far worse than Zoom video visits.
Yeah, that's true.
So,
That is certainly true. Yeah, one-on-one visits are more rewarding in Zoom than large group meetings. Here's a question that's a little bit specific to our program, less so COVID. So I apologize, but indulge us here for just 1 second. Since Dr. Varga and Dr. Hinchcliffe are no longer at Northwestern, do we still have a research going on in scleroderma? And just to answer that real quick, absolutely. Still, both Dr. Dematte and I are actively involved in research, and it takes a number of different forms. But certainly not the only site for scleroderma care or for research in scleroderma. Another question that we got here is for OFEV. So this is nintedanib. This is a newer antifibrotic that some folks are on for their interstitial lung disease in scleroderma. The ACR guidelines do not address the antifibrotic medicines, so specifically OFEV. So at the moment, this is a very kind of individual decision based on the provider, as far as I know. But Dr. Dematte, do you know more than I do about the use of that medicine? And specifically when it comes to getting your vaccine?
Vaccine, yeah. So there is no, although we know it has some immunomodulatory effects, it is not considered really an immunosuppressant. And the Pulmonary Fibrosis Foundation recommendations are to get vaccinated. You do not need to stop OFEV for vaccination. You should continue it, and you don't, like the other medications, no need to hold doses at all. So
great, thank you. I might have to leave for a second just to take them away for a moment. But another question is, how long does the vaccine last? And a related question that there's quite a few questions on here is there going to be a booster? What do we know about the booster? On my end, unfortunately, we have to be fairly honest that we don't really know how long the immunity to this vaccine is going to last. It is a new vaccine with a new mechanism, and we're not sure. The questions about the booster is also a very great question. What I can say is that both Pfizer and Moderna, with their technology, they've already said that they can adjust their vaccine to go after kind of a variant protein within about 6 weeks. But the production of that new vaccine is going to be different. The FDA has already said that if they are adjusting, making kind of minute adjustments, but going after the same overall protein, that they do not have to get a reapproval for the new vaccine type. They just need to do post, they call it surveillance, surveillance after it's been released. So those are the main things that I know about the answers to those two questions: how long it lasts, and what do we know about boosters? Dr. Dematte, do you know anything else?
Yeah, I'll bring up one other thing along those. So I agree with you. We don't know how long it will last, and it's not an easy question to answer. Studies, both Moderna and Pfizer, are continuing to surveil their study populations to hopefully answer some of these questions down the stream as those patients are being followed. But I'll also mention, because there's another question brought up about whether or not patients with autoimmune disease, whether they're on immunosuppressions or not, can mount a good response to immunization. That is something we can somewhat measure. I won't say our measurements techniques are as, if we know them to be clinically useful, but we can measure your immune response by measuring how many immunoglobulins you have made to the spike protein. So the spike protein is what the vaccine is all about. The spike protein is what's on the wall of the virus and allows the virus to bind to a cell and then infect that cell. So what the vaccine is intended to do is to provide antibodies against that spike protein, and those can be measured in your blood. And those are the measures that, you can detect that in your blood at peak levels about 2 weeks, 1 to 2 weeks after your second vaccine. So although it's not recommended by any society at this point, in part because we don't know that that means you're protected or not, it's at least one measure saying, yes, you did make those antibodies against the spike protein. And so we have been sending those in some of our patients who are on immunosuppressive medications and having them timed about 1 to 2 weeks after the second. And what we've seen so far in the handful of patients who have done this is that the levels are definitely up there in the range of where we would expect them to be. So that is shows us at least that we can make, even people on immunosuppression can make antibodies to the spike vaccine after they are vaccinated. We don't know how long those will hang around. And the more important thing is we don't know if you even, it seems like it would be easy enough just to follow those IgG levels. But the truth of the matter is following those IgG levels doesn't tell you, when they go away, that doesn't mean you're not still immunized. You may still have the memory cells, which is the other way that vaccines help us fight infection for longer than just the period that you maintain those immunoglobulins in your blood. The memory cells are the way you quickly rev up and develop new immunoglobulins if you see the vaccine. So it's not that easy just to follow a blood test. I mean, it takes a little bit more to know whether or not you are still immune to a virus. So I think that data will hopefully be coming, but at least if you're interested or anxious to know whether you at least mounted initial response, we do have a pretty simple blood test to look at that. I know, Chase, you might have mentioned, Dr. Correia, you might have mentioned that patients said it wasn't covered by all insurances. I don't know that I've had a problem with that yet, but.
Yeah, so I haven't yet had a patient who has told me that they have received a bill as a result of getting that antibody test. However, there was a patient who was told kind of very sternly by their doctor that it probably would not be covered. So unfortunately, that's one of those things, and there's so many different insurance companies out there and so many different regulations. It's not something that we're able to know unless it's something that's pretty uniform. It seems like it's generally being covered, but there's maybe some possibility that either now or in the future for some insurance plans that's not being covered. The ACR guidelines do specifically say that they do not recommend that it gets checked, in all circumstances or routinely. So it's something that, it very kind of individually dependent on the patient and the doctor. Oh, go ahead, please.
I think the recommendation against checking it again is, as I pointed out, we don't really know what the implications of having a high level, a low level. And also, if you have a high level, it does not mean you're protected against all of the potential variants. As we said earlier, I think there's a sense that it might give a false sense of security to say, oh, well, you have a good immunoglobulin level. And I think there's some truth to that. So just keep that in mind. Even if you do have it tested and it is high, it doesn't mean you should cease with all of the precautions we've been taking.
So a couple other questions that are both related to kind of using MyChart as effectively as possible. So one person asks if it's effective to send a MyChart message ahead of time with questions or concerns. Is that helpful? Another question that was on MyChart, oh, I lost it here. Let's address that first one first. So I think where that is sometimes effective is just in organizing your thoughts and organizing kind of your concerns. And so that can be helpful there. Dr. Dematte may know, may have her own workflow that's different from mine, but I know on my end, if you send it, any less than a couple of days in advance of that visit, it's unlikely that I'll have seen it ahead of time, especially because I mostly see scleroderma patients on Mondays and Tuesdays. So it's kind of a straight shot, and I don't have a whole lot of time to look at my chart messages on those days. Dr. Dematte, do you have thoughts about patients using my chart as effectively as they can, or how to use it most effectively?
I do. I mean, somebody asked about Zoom fatigue. Well, I can tell you inbox fatigue isn't.
That's a real thing. Yeah.
A huge number of inbox messages. And it can really be exhausting. And some of them, many of them are entirely appropriate. And we certainly would never want to put barriers in the way of people reaching out to us with medical questions. But a lot of things that come in are more appropriate to bring to the visit. And because of that, like Dr. Correia said, we may not always be 100% up on our box. So I think a better way is than sending it to us in advance is really just have your questions with you on the call, so you make sure you get to all of them and have a chance to address them.
Yeah. I've increasingly, for whatever it's worth, been telling folks that I tend to be able to answer my chart messages on Thursdays, which is the kind of designated day I have for doing that. So I do appreciate everyone's patience. If it's something that is truly urgent, that needs to be answered before Thursday, please call, is what I've been telling my patients. But every doctor is going to have their own workflow with that, and that's just me.
Mm-hmm.
Let's see here. Go ahead.
Chase, this might be an opportunity for me to jump in with the my chart. I mentioned to people that although COVID has settled down for many of us, those of us still doing the ICU, we still have a high number of patients yet in the ICU with COVID-related infections. So our pulmonary group does all of the critical care here for COVID as well. We're still running 2 extra units. So we're nowhere near to our baseline. And the weeks I'm in those units, it's very hard for me to be going back and forth between the inpatient and the outpatient and getting to all of my inbox messages. So I just want to bring that up and ask you, please be patient as those of us who do critical care are continuing to struggle to get back to normal in terms of visits and our ability to be as responsive as we would really love to be for our outpatients. It's still just not possible for me. So.
And that's one of those hard things that I see it all the time, that people really want the best for their patients and really care deeply about their patients, and it is a tough time on the entire system of medicine right now. And we know it's tough on all of you too. I mean, it's a tough time in the world's history, but I think especially with Dr. Dematte and myself, we really team with our patients and value that approach. A very specific question: who should be tested for antibodies after the second vaccine? I think this is the type of question that, honestly, if you asked a number of providers, you may get a number of different answers. But I think the one that probably Dr. Dematte and I would be kind of most interested in, or at least we might present it as an option or a recommendation for folks, is those who are on Rituximab. And the reason for that is a really good one, and that's just that the mechanism of Rituximab is much more involved in the types of cells that produce antibodies and kind of memory to viruses and bacteria and vaccines and things like that. So I think that's the main role that probably there would be the most consensus on. Dr. Dematte, do you have other thoughts there?
I'm sorry, I was looking through questions.
Oh, no problem at all.
I didn't hear what you said. I apologize.
No
I'm just
worries.
going through some of the other questions in here.
Yeah. Thank you, Ceci. So yeah, so I do think generally the most consensus would be around testing for antibodies for those who are on rituximab who get the vaccine.
Right. Mm-hmm.
There's also, a fair number of questions regarding that either a patient or a family member had COVID in the past. And one common question is, can they get COVID again? And unfortunately, this has happened. There's no question that people who have had the COVID vaccine in the past have had it again. It is not common, thankfully. It is not common. It's not totally clear if it's something unique to the individual or just something that can happen, in the normal course. But it does seem to be true, at least the last time that I saw data released on this, that frequently the second infection is thankfully not as severe. Dr. Dematte, do you have other thoughts on that?
No, I would agree with that. There's clearly been demonstration of second infections. There was actually a healthcare study looking at healthcare workers. They looked at 102 healthcare workers. I have a couple of notes on this, and follow them over time with swabs after some of them had vaccines in between and others did not. But of those who weren't vaccinated before, who weren't vaccinated in the interval period, a very small percent, but I think it was like 17%, so maybe not that small, did test positive again at one point, but more than half of those were asymptomatic positive tests. So, and the rest were all mild infections. So, and I will say though, we have had some people who are really severely immunocompromised. And some of these have been organ transplant patients or on multiple immunosuppression who have had recurrent infections that have landed them back in the ICU over the course of 1 year. They have been extremely rare. We have seen a few of those, and I think those are people who likely have not only immunosuppression, but whatever their underlying disease is has also led them to have innate immunodeficiency syndromes. So I think short of people who are severely immunosuppressed, the majority second infections are relatively mild, but have been demonstrated.
Okay, well, I think we really covered pretty much, at least maybe not everyone's specific questions, but all of the topics that have been brought up with these questions. Dr. Dematte, do you have any kind of final thoughts or things that you want to cover there for everyone?
No, I think we're running out of time here. I see there's just a ton of really great questions, but unfortunately, and obviously we can't answer them all. So I hope you found this useful, and certainly feel free to reach out to us with other individual or pressing questions. I wish we could answer these all, but I don't think there's enough time.
Yeah. I've shared this thought with a lot of folks, but this has been a really challenging year, and it's really normal and very common to be stressed out by this year and to just feel like life is challenging right now, and it absolutely is. But I think regardless of which vaccine you're looking at, these really are just major advancements in the field of medicine that we have not ever been able to do something like this so quickly. And it's really kind of incredible that we're hopefully, we don't know some things like the variants and, necessarily how long immunity lasts and things like that, but hopefully we're starting to see the dawn of, the sun coming up on this COVID situation, and, a lot of improvement. I'm not sure if you're able to see me, but my daughter is knocking some toys against my head. So that is probably my signal that time to go. But really appreciate everyone coming on, and absolutely send questions or comments or concerns our way.
Great. Well, I want to give a huge thank you to Dr. Dematte and Dr. Correia. That was extremely helpful. A lot of great information. Thank you for putting together the slides and preparing all this information. That was really great. So, and thanks for taking the time out of your busy schedules to do this for us. Just a reminder, if you're feeling isolated, please connect with one of our support groups. You can find out about those, and they're all meeting online virtually, so it doesn't matter where you live, you can connect with them. You can find out more about those and our other resources at scleroderma.org/GC chapter. And I think that's all we have for you today. Thanks everybody for joining us, and thanks again to Dr. Dematte and Dr. Correia.
And thank you so much, Stephanie, for getting this all organized. It's a great way to get information out.
Very helpful. Thanks everyone. All right. Take care.